I'd now like to invite Dr. Betsy O'Donnell from Dana Farber Cancer Institute to come up to the stage. She's going to be giving us a lightning updates for the day.
All right, thank you. Ooh. All right, good morning. Thank you all so much. It's my great pleasure to be here. I have the privilege of introducing the topics for a number of our speakers. We're going to be covering 6 different hematologic malignancies. For my portion of the program, I'm going to leave the discussion to the experts, but give you some of the highlights that I've extracted from their talks that will really bring to the front the most recent publications and presentations. These are my disclosures, but perhaps my most exciting disclosure is that I'm actually returning to this very Marriott/Hyatt after 28 years. I worked here in 1995, and it turns out I'm not the only one who worked here, so this is an alumni day of sorts for many of us. I think I'm probably the only banquet server to return as a banquet server, but here I am in the same room. Anyway, all right. So for today, we'll be covering CLL, multiple myeloma, and lymphoma. And I'll have Dr. Graf today as our presenter for CLL. We're very much looking forward to hearing her presentation. She is actually going to go through in great detail the key study updates from ASH 2022, which include Captivate, GLOW, Alpine, Bruin, and AVO. And so Captivate, which she'll talk about in detail, was actually a randomized phase 2 study assessing the safety and efficacy of first-line ibrutinib and venetoclax. There are 2 cohorts. One was fixed duration and the other was based on MRD. She'll present the 3-year fixed duration update. As you can see, there's a fixed duration of ibrutinib that's administered, then venetoclax is added to the regimen for a total of 12 cycles. In the other arm of this study, it's the same regimen, but based on MRD status, the patient goes on to a different management strategy. She'll next present GLOW, which is again fixed duration ibrutinib and venetoclax versus chlorambucil and obinutuzumab in frontline CLL. And this is for elderly patients with comorbidities. The next study will be Alpine, which is also a randomized study. This is a non-inferiority phase 3 study comparing zanubrutinib and ibrutinib. She'll then move on to the Bruin study, which is a study of the efficacy of pirtobrutinib in covalent BTK inhibitor pretreated relapse refractory CLL. This is a highly selective molecule. It's well tolerated and demonstrates promising efficacy, and she'll talk about it a lot more in her discussion. And finally, the AVO study. As we'll hear, there are different themes across the many hematologic cancers, and some of them is really increasing the number of drugs in combination to better fight the diseases that we treat. This is a study of the combination of acalabrutinib, venetoclax, and obinutuzumab. Again, there's stratification based on response. Patients who achieve MRD negativity will hold treatment with the option to restart therapy if MRD status changes, versus those who remain MRD positive will continue on the doublet of acalabrutinib and venetoclax. So that is going to be a really exciting presentation. Those will be the highlight topics for her discussion. Next, we'll move on to my dear colleague, Dr. Yi, who will be taking us through a whirlwind tour of myeloma. Get some coffee beforehand. He will touch base on newly diagnosed myeloma. He'll talk about the treatment of relapse disease. We'll dive into anti-BCMA-directed CAR T-cell and bispecifics. Beyond that, we'll look at other therapies, non-immunotherapies for the treatment of relapse refractory disease, and then we'll look forward onto the horizon with new therapeutic strategies. So he'll begin in the newly diagnosed phase. And again, we come back to this issue of 3 versus 4 drugs. And he'll present some of the more recently presented data about the addition of daratumumab, which is a monoclonal CD38 antibody, to our classic combination of lenalidomide, bortezomib, and dexamethasone. He'll talk about the transplant ineligible patients and present the updated MAIA data, which is the addition of daratumumab to lenalidomide and dexamethasone in transplant ineligible patients. Looking a little bit deeper into the frail population, he'll cover the IFM 2017 data, which looks at the use of low-dose dexamethasone in these classic combinations, trying to spare older elderly patients the added toxicity. He'll also look at anti-CD38 monoclonal antibodies in relapse disease, specifically looking at updated data from phase 3 studies of carfilzomib and pomalidomide in the relapse setting with the addition of daratumumab or isatuximab. I think we are so fortunate in myeloma to now have 2 approved CAR T cells. We now have ide-cel and cilta-cel. It's been exciting for Dr. Yi and me, who really did these together from the beginning of ide-cel. And so he'll look at some of the newer cilta-cel data that was presented at ASH. He'll specifically cover some of the overall survival differences between the 2 available CAR T cells and compare those to standard care therapies or other FDA-approved therapies in this same heavily pretreated population. Again, we'll continue on the theme of anti-BCMA CAR T cells with the KarMMa-3 study, which is a randomized study of ide-cel versus dealer's choice for relapsed disease. In a similar fashion, he'll cover recently released updates on CARTITUDE-4, which, similar to the KarMMa-3 study, is a randomized study of cilta-cel versus pomalidomide, bortezomib, dexamethasone versus dara-pom-dex. I think the really exciting thing about having these new therapies, as we all appreciate, they have to start in the heavily relapsed population, but having the opportunity to then move them forward into earlier treatment. So there are 2 ongoing studies that he'll discuss. One is CARTITUDE-5, which is for transplant-ineligible patients, that introduces CAR T cell upfront after induction therapy with a classic combination of RVD. The other is the CARTITUDE-6 study, which is a randomized study of RVD dara induction with auto versus cilta-cel. Teclistamab is a BCMA-directed bispecific T-cell engager that was recently approved this fall. So again, another exciting addition to our myeloma armamentarium that Dr. Yi will discuss. Looking at anti-BCMA bispecifics in the maintenance setting. So there are ongoing trials looking at standard induction followed by bispecific T-cell engagers randomized into our maintenance phase. And so we see that both with teclistamab and elrantamab, which is another BCMA-directed bispecific. He'll also talk about teclistamab in the MajesTEC-7 study. This is a randomized phase 3 study in newly diagnosed transplant-ineligible patients where they will get, it's kind of building off the Maya data where we're adding teclistamab to daratumumab lenalidomide versus the combination of dara-lendex. So, for those of us who treat myeloma, it's wonderful to have all of these options, but we know that patients relapse beyond that. And so, the next wave of therapies is really exciting. So one of the other targets being explored is GPRC5D, and so talquetamab is one such bispecific that is being studied that he'll discuss. There's also ongoing phase 3 studies, randomized for patients who are previously treated, introducing talquetamab with other therapies for relapse disease. We also have GPRC5D CAR T cells. So this is also a very exciting additional option to have for patients. Some patients may have gotten a BCMA-directed bispecific first. This becomes an option for those patients. We also have other targets. Cevostamab targets FcRH5, which is another bispecific in development. So I feel like we're spoiled by all of these updates and opportunities presented this year at ASH. And finally, beyond immunotherapies, we have the development of newer, stronger immunomodulatory drugs or CELMoDs, including iberdomide and mezigdomide, which Dr. Yi will talk about as well. So following Dr. Yi will be Dr. Kamanduri from UCSF, and they will discuss lymphoma. And so they too will begin with bispecific antibodies in non-Hodgkin's lymphoma. Mosunetuzumab monotherapy will be presented in the relapse refractory follicular lymphoma study. We'll hear about a bispecific glofitamab in patients with relapse refractory DLBCL. We'll hear updates in CAR T-cell therapy in non-Hodgkin's lymphoma. Specifically, we'll hear a lot about the updated results of the ZUMA study, and this was for patients with relapsed refractory lymphoma. And then the question of whether or not cell therapy should be standard of care for second-line therapy in diffuse large B-cell lymphoma is a really important and interesting one. And again, in that context, the ZUMA study will be discussed. One of the critical questions for all doctors when they choose the therapies that they'll be using is what is going to work best for patients. And so trying to pre-identify who may or may not benefit or who may ultimately have a shorter duration of cellular therapy is critically important and will be discussed. One such model for trying to optimize CAR T-cell therapy was proposed by Spiegel and Miklos, which will be discussed today. And I think finally, and perhaps most importantly, the discussion of access and equity within our novel therapies. This is a geographic distribution of cellular therapies. You can see very clearly where these therapies aggregate, and there are large swaths of this entire country that do not have access. As we think about the resources that go into the development of drugs and therapies, I think it's important to have an eye on who has access to those drugs. Now, it is not uncommon for things to be developed in academic centers, but we have to make sure that they can be available to other people and not just within the small communities who are able to offer them because they are label intensive. And not only that, within the communities that do have access, making sure that they're broadly available to people of all races, ethnicities, in an equal and fair distribution. So we have a lot of exciting topics to cover today. I want to thank in advance all of our speakers this weekend. Thank the organizers for having this conference here, of all places. It's great to be here, and I ask you all to sit back and enjoy a wonderful day. Thank you so much.